Hi, everyone, and welcome to the Global P.A.D. Impact Awards, where today we are honored to announce the recipient of the P.A.D. MacGyver Award, Dr. Carlos Bechara of Rush Hospital in Chicago, Illinois. This award recognizes physicians who demonstrate exceptional resourcefulness in peripheral artery disease cases. Peripheral artery disease, or PAD, meaning poor circulation in mainly the leg arteries caused by plaque buildup. Dr. Bechara has earned a reputation for finding solutions when others determined intervention was just not possible. Patients consistently have reported that when faced with potential amputation, Dr. Bechara's innovative approaches and determination help save their limbs and restore their mobility. His ability to develop personalized treatment plans and adapt techniques during challenging, and I'm talking challenging procedures, has made him the physicians that patients seek when conventional approaches have failed. So I am so excited to welcome Dr. Bechara to discuss his approach to complex PAD cases and to hear about the patients whose lives he has truly transformed. So congratulations, Dr. Bechara, our 2025 MacGyver of the Year, someone who absolutely refuses to give up on patients and exhausts all limb salvage options, even if it involves a little bit of ingenuity and creativity. So, Dr. Bechara, as we welcome you, we must know the source for your relentless fight for patients with PAD.
Yeah, Kim, thank you so much. I mean, really, I'm honored because, obviously being recognized by the patients is something, that's why we come to work every day. That's what keeps us going as physicians and as surgeons, because we want to make an impact. And also what you're doing, I have to say, I mean, it's also amazing because a lot of these PAD or peripheral arterial disease patients, they're desperate. They're looking for answers, they're looking for options, they're looking for someone who's going to say, hey, I could help you. And, sometimes we can't. I mean, I have to, sometimes we can, but at least someone who's able to help this patient, whether it's with open surgery, whether it's minimally invasive surgery, or whether it's hybrid, that's my favorite operation, and my kind of where my creativity comes is when I'm able to combine open surgical techniques with endovascular techniques or minimally invasive techniques to try to save a leg, and which has really served me well, and I was able to help a lot of patients. But thank you again. This is this is really. I can tell you, my kids love the name of the award, so so thank you for doing this too.
Your kids know who MacGyver is. Do you remember MacGyver?
No, they don't, but they like the name. But I know, yeah.
But it's truly, I mean, MacGyver was called MacGyver because of that, the ability, the resourcefulness. And, this is something that patients came up with. And someone you probably know really well earned it last year, Dr. Miguel Montero Baker out of Houston with Hope Vascular, because he's also very creative, things I'd never heard of. Patients will come to me and say, so he's talking about doing X, Y, and Z. And I'm thinking, that's not in the textbook. And that was the same with one of our patients that you treated recently. I was like, I don't know. I would trust him with my heart, my soul, my legs, everything, but I have never heard of that.
Yeah, thank you.
And it worked.
Yeah.
And so, patients consistently mention this willingness that you have to take on these cases that others do deem unfixable. So, I wanted to, I have quite a few examples, but I want to hear some of your examples. Share one of your particularly challenging PAD cases where you had to develop a very unconventional solution that maybe you even kind of surprised yourself.
Yeah. Well, I have several, but if I want to tell you a story on a patient that really left a lot of impact on me, and also made me recognize how much we can help patients. So this is a patient that came to see me several years ago. Was high-risk patient for amputation. Now, we can talk about risk factors, but this is a morbidly obese patient, end-stage renal disease, diabetes, and he already developed a wound on his big toe. And they tried everything, and they said, you know what, that's it. Your only resort is a below-the-knee amputation. So he was actually sent to me for an amputation, to look at it and see if he should have an amputation or not, and whether I can do something. So when I looked at the images, um, I realized, as we know, all these patients that have tissue loss, which are the high risk category for losing their limbs.
Yeah.
They have what we call multi-level disease. They have disease in the iliac artery, which is the inflow to the leg. They have disease in the thigh vessels, the femoral arteries, and tibial disease in the legs. So, I mean, I get it. He's morbidly obese. He was refused a kidney transplant, and but then when I looked at his images, I mean, I knew if he traditionally needs a bypass from the groin to the somewhere in the foot. But I knew because of his obesity, he's going to what everyone was worried is about infection. If he gets a groin infection with his comorbidities, he's going to, pass away. So I thought about, then making an incision just above the knee, where I exposed what we call the popliteal artery. I cleaned it out, put like a patch on top of it, and I stuck the patch and went backwards. And I really opened up all the vessels, the iliac, the common femoral, opened them up, ballooned them. Luckily at that point we had shockwave, which is a lithotripsy for like very calcified vessels was around. So I used that technology. And then I stuck the patch and went the other way. And then I fixed the tibials and it worked out amazing. I mean, really, I mean, I was honestly myself I was like shocked how well it worked, that to the point that he eventually healed his toe and avoided an amputation and came back a few months later for the other leg, which, also happens in these patients. I didn't do something similar. Luckily, it was something simpler to do. We fixed it. But here's the best part, Kim. He comes back a year later to my clinic to say hi. And I didn't recognize him. He lost so much weight because he got so motivated that he has both legs. He avoided bilateral. Literally, I mean, this guy was sent to me for bilateral amputation. I mean, you can imagine the lifestyle. Um, I mean, with his obesity on the wheelchair, I mean, would have been terrible. Not only he lost weight, he's back on the transplant list because he lost weight. I mean, it was
I'm
like, I mean,
getting
this
chills.
story, yeah, I mean, this really, like, he almost put me to tears, honestly. I mean, in clinic, because I mean, I couldn't believe it, that the impact that we made on this patient, and how we motivated him to like, it was kind of like um for him to recognize, what, I also need to do something different with my life, and he did, and good for him.
I'm wondering, and I don't know if this is a fair question, but it's coming to mind that do you think that if he didn't have the threat of bilateral amputations, both legs, that if you would have just said, I could just fix that, I'm going to go ahead and open up your arteries, I'm going to do all this work and I'm going to send you home. Do you think that it would have had the same impact on him, and been as much of a motivator if you were the first person he saw and he had leg pain and you were just like, oh, I'll just go in and fix it. Okay, go home and just walk, 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 keep them open. I don't know. Some may not.
Yeah,
I mean, sometimes you do need the fear of God in them in order to get them motivated. And even still, for some, that's not even enough.
correct,
It could have
correct.
the opposite effect.
Yeah, I mean, the biggest one, honestly, Kim, and then I try to be compassionate about, is smoking. We know smoking is a big um, risk factor for PAD,
Yep.
peripheral arterial disease. And but I feel bad for these patients. Not only they have, they lost part of their foot or stroke or heart attack. It's hard for them to get off those cigarettes.
Yeah.
I mean, I get it, but I try to kind of educate them, be a little bit compassionate about it, because you can't just say, hey, cut off those cigarettes, because, that's not going to work.
Mm.
But that's something, I agree with you. That's so hard to convince patients, despite what they're going through, or they've been through, to really quit those cigarettes.
Yeah, that's funny you mentioned we launched a 12-week program through our association on Monday nights. So it's a weekly meeting. We talked before this about the power of community. And so we have a community that gets together on Monday nights. And we have a couple of moderators, who are both addiction counselors. And it was interesting. We're getting ready to do potentially a study with a PhD student out of Arizona and applying for a grant, because what we've learned is that in all the materials that are out there, they all say, well, people with peripheral artery disease who smoke are not typically impacted by all of the other programs that are out there. There's something different about them, and
Mm,
something needs to be done. And so we went direct to the patients and said, hey, what would work for you? And we designed a PAD specific program around them. And, some end up quitting right away, and others just end up doing less. But you know what? Each one of them shows up every single Monday.
well, well,
Um, and as long as they're showing up, you still have a chance to reach them. They're still trying. And
mm,
it's pretty remarkable. They do need support. And so many of these patients, and I don't know what your experience, if you've gotten deep into the relationships and learning about their past, but we've known a lot of PAD patients that when we're talking to them have been through a lot of trauma in their lives. And so it's really hard. I mean, we've had a young man who watched his mother shoot his stepfather and ended up, trying to turn the gun on him, and he got away and ran away. And he's just had this trauma in his
mm,
life. And with PAD, I mean, we've had all kinds. And so I think it's just there's so much more to these patients, and that we need to modify a lot of these programs to be able to reach them where they are and show a lot of compassion and understanding.
mm, mm. Yeah, I also add to that. I agree with you. I mean, they've been through a lot. Also, the financial burden. I mean, a lot of these
Yeah.
patients who have, especially who go through wound care, I mean, that's a lot. And also the anxiety of losing the leg, the anxiety of having to, go see multiple physicians and specialists. It's a lot.
Yeah, and that's where we also try to help them with the navigation, keeping
Mm.
track of all their appointments and
Well,
making
well.
sure they're mapping out their entire strategy, going to the endocrinologist, going to the PT, going to the vascular,
Mhm, mhm.
going to, right? And
Yeah,
that's really helpful to have someone, holding your hand along the way.
that's awesome.
But that, back to the award, the MacGyver Award recognizes your ability to adapt techniques just mid procedure. I mean, just stop down. We got to go in a whole different direction right now. And I'm just wondering how you prepare mentally and technically for these unexpected challenges that you face, and what resources do you really rely upon most? I would imagine with your personality, you'd be like, okay, game on, here we go.
Well, Kim, I was fortunate to train, I trained in Houston. I had really amazing mentors who were also outside the box thinkers, who I learned from them, how to think outside the box, how to be creative, how to be innovative, and definitely they left a huge impact on me, and I will always be grateful to them. But you're right. I mean, there's something we have to also do as physicians and interventionalists, where we have to go to meetings, like you mentioned, Montero Baker. I mean, he does things that I don't do. I mean, I'll be honest. I mean, he's very creative too. So you have to go to meetings, you have to learn. We also have to improve and develop skills as we go. I mean, that's why I tell all my trainees when they graduate is that, you're going to be doing stuff you never learned during your training, during your fellowship. So you have to keep an open mind and learn from others. And same thing here. I'm lucky to work with my interventional radiology colleagues, which I'm sure some of them and they're very talented. They're very good. They're very talented. So if I'm stuck on something, or I think they might be able to help me with something, I have no problem reaching out, because I want the patient to do well. I want a good outcome for the patient. Doesn't matter if I do it or someone else does it or we do it together, as long as the patient um, develops with the result that we want. But yeah, you're right. I mean, I learned from them how, if you face the problem in the operating room, how you can fix it, bleeding problem, not able to go through a blockage. So all these, I was able to kind of, I have the ability, with the training and the experience to kind of think on the fly and develop things. And one of them, one time I was doing this surgery on a patient who has a completely occluded aorta and iliacs, and the patient was was not a candidate for open surgery, what we call aortobiafemoral bypass. Great operation, but it's not for everyone. And I remember I was able to pass the wire, but I strayed what we call subintimal. So I'm not inside the true lumen where we can actually get the wire out and stent. Then I, kind of like this idea came to me. I was like, well, if I just make a small incision in the groin and I take that wire out and I just clean the vessel around it, and now I have, through the wire through the blockage, I'm able to create what we call a landing zone in the groin and put a stent into retrograde. And I remember I gave a talk on it a while back. This was like, I don't know, over 10 years ago. And then and actually one of my friends in New York, he developed it. He has developed similar technique, what we call it the wire first technique. But yeah, I mean, this was I would say was one of the like kind of like aha moment where we're able to expand our hybrid approach to treat more and more patients. And also, I do have a technique that was published in our Journal of Vascular Surgery, where we treat something like called flush iliac occlusion, where the vessel goes in and splits, and there's really no room to see where to go the wire. So I developed a technique where I come from the arm and block the path of lead resistance with a balloon, and that allows me to go with wires and catheters into the area where I can't see, but I kind of predict where it originates. And yeah, we published that in again maybe 2012 in JVS, and I know many people used it, which was nice to have people call me like, hey, I used your technique and it worked really well. I mean, now I don't think we have to use it as much because now we have the technology advanced so much. We have something called steerable sheath, and that really helps me to navigate through these tough occlusions. But I can tell you, those are one of my favorite operations to treat these complex iliac occlusions with some creative hybrid techniques and to try to fix them and avoid like a big open operation.
So, what really drives your determination to find these hybrid approaches and basically just alternatives to amputation, even in cases where other providers might have suggested it was just absolutely inevitable? And I ask this because there are a lot of doctors that tell me all the time when I bring up things that certain surgeons that I know, like you or like Dr. Baker or Dr. Dexter over along the Virginia coast there, um, are doing, or Dr. Hayes out of Swedish over in Washington,
Mhm.
that you guys are so creative. And the answer that I get is there's not enough evidence for that. So, what's the difference? How do we get that mentality to change? Because when I think of a vascular surgeon, I think of a creative mind. Like that's what I would think. I think of an Anida Dubois as well. That always thinking, wanting to create something. It's like this is your platform. Like the basics. Like now you can create. You could do anything that you want as long as it's safe. Why does it have to be already evidence based? Why don't you help be a part of the change that we all want to see and help to create the
Yeah,
evidence? If amputation is on the table, then if you're not going to do more harm, then why not try?
yeah. So great question. So I'll answer in different ways. One is so just so you understand what my approach to these complex problems. So what I tell my trainees is that adopt technology, be on the forefront of technology, but also you owe it to your patients to look at your data and see what can I do to improve this technique, or if this technique doesn't work, you shouldn't be doing it. So, I mean, I can tell you when I first started doing these complex cases, my results were okay. They were not the greatest, but when I looked at it over time, they were getting better. Why? Because my techniques improve. We have covered stents now. We have balloon expandable cover stents, so we're able to, with the technology, utilize other techniques to improve our results. So be a part of the solution, so think of how we can improve. So, and then a famous cardiovascular surgeon in Houston by the name of Dr. Hazem Safi told me, if someone has done before didn't work, that don't ignore it. Maybe they didn't do it well, or maybe it can be done differently. And then I agree with him. I mean, I thought it was like an amazing that he actually gave me kind of that insight. and because there are ways to make things better. Now, again, to your point, when we see patients, again, this is a story a long time ago in Houston when we first started doing these pedal access, what we call retrograde access. Same thing. I had a patient was being literally faced with amputation. She saw I don't know how many people already, interventionalists, vascular surgeons, and then everyone telling her, "Oh, I can't stick your perineal. It's your only outflow to go retrograde." And she came to see me. I was like, "No, I'll do it because if I stick it." And then I save you, well, I might save your leg. And then if I stick it and I, mess it up or whatever you want to say, you're going to be heading to an amputation regardless. I did. I was able to access it. I was able to fix her leg, and she did. I mean, I remember that lady. I would never forget. I forgot her. I'm shame I forgot her name because when I first went, when I saw her in the hospital after the procedure, she was in tears, and I asked her, "What's wrong?" She's like, "This is the first time I sleep with my leg on the bed."
Oh, that is so awesome.
Yeah.
Isn't that incredible?
Yeah. And I get it. I get it. People don't want to stick her only vessel. But again, like you said, she's faced with an amputation. I mean,
Yep.
that's her only solution that many people have told her. And I was like, well, give me one try. Let me try this. I think I can help you if it works. And it did. Again, maybe it wouldn't have worked, but it worked. And that's why I think for the others who say, show me the evidence, well, I mean, depends. I mean, there's a lot of evidence for these hybrid procedures that work very well, by the way, and they're as good as open surgery. But also, when we're faced with difficult situation, we also have to be creative and think outside the box to help these patients.
We still have so many doctors that literally will just tell our patients that you're blocked below the knee. There's nothing we can do. So let's just amputate. Like, let's not. And I always say, well, did they try a different approach? Did they try not just antegrade, but did they try retro, pedal access, going in the calf, going behind the, like, did they try something else? Because I'd love for our patients to understand um, what you face when you go antegrade sometimes versus retrograde in terms of the cap. And I'd love for you to explain that in layman's terms, in patient terms, so they understand, because I tell them all the time it's just different. For these doctors, that sometimes it's just more amenable when they come up from below.
Yeah. So you're using a terminology antegrade, retrograde. So antegrade is the way the blood flows to the leg. So obviously it goes from the heart and then goes all the way down to the feet and toes. So that's what we call antegrade. And that's what we try to open up most of blockage, where we actually follow the path of the vessels and we use different techniques to try to open up the blockage. But sometimes, this blockage is either long segment, which means like it involves a long area from the thigh to the knee, all the way down sometimes, or even higher. And sometimes it's hard to cross, with just using antegrade. So what people thought about, okay, what about if I come from below? Below means like stick somewhere in the foot or the leg around the ankle and try to come up with a smaller, profile wires and catheters and try to see maybe meet halfway or maybe go all the way. So there's different techniques that have been developed over the years by really creative interventionalists, how we're able to kind of have the two ends meet, coming from top, coming from below, to fix this blockage. And yeah, I must say, I mean, those have worked and helped a lot of patients. Now, again, I don't want to say like, I know we're talking about PAD, but sometimes like I was, as a surgeon, I've done amputations. I mean, I'm not gonna say, look, I'm
Yeah.
successful 100% of the time. I mean, unfortunately, there's a lot of times infection, and that's why that's why I try to educate my patients, especially the ones who have diabetes,
Yeah.
is that if you see a tiny wound or ulcer in your foot, come see me like then.
Mm.
Don't wait until the wound is worse or you have an infection, because unfortunately, a lot of times, even with adequate circulation, we can't get rid of the infection or bone infection. But you're right. I mean, we owe it to our patients to if there's something, like I said, I cannot handle or do, and I'll call my interventional radiology colleagues and say, hey, can we look at this case together and see if we can come up with an idea or plan to try to use your skills, my skills, and then hopefully we can do something to help this patient.
Yeah, I love that you work together collaboratively versus working against each other, just recognizing that, when it comes to the treatment, there are plenty of patients to go around. I mean, we have patients that can't even get in for months in certain hospitals.
Yeah,
And
yeah.
so sometimes even a year across the
Wow,
pond.
wow.
And so it's nice that everyone's working together and recognizes that everyone might have, a different set of skills. Or someone just even has, I mean, you've probably had cases even where you thought, you know what? I couldn't get through. You send them home, they're on deck for amputation, and you go home, you can't sleep at night because this is just bugging you. And you call them up the next morning and you say, you know what? Just give me one more try. I just need one more try. And in that one, you had a different eye on it and you get right through. I mean, it's incredible, but it's the passion, it's that drive, right? It's that commitment, to the patients and trying to do everything possible, recognizing that losing a limb is not only life-saving. You bring up a good point. There are situations where we always ask patients, is your life on the line? You need to ask the doctor. Are you at risk? That's first. But if not, you know, losing a limb can be life-changing.
It is. I mean, it's devastating to the patient, to the family, because now they're relying on other people to help them with their
Yeah.
daily activities. It's a life changer. So yeah, I agree. I mean, and to your point, if sometimes let's say I'm doing something, I'm successful, maybe because I didn't have the right tools. So, and again, that's something we always tell our trainees is that you've done no harm. You can always come back. It's okay if you come back. Don't keep doing something and cause more harm or problems or bleeding or. So let's say for some reason I didn't have something available on the shelf, and then I would stop and then bring the patient when I have all these tools available. Or like you said, maybe I'll call a colleague and say, hey, let's put our mind on this tough case and and try to fix it. And I've done this a few times already here at Rush. I mean, I've been at Rush now 8 months, and we've done it multiple times to really try to expand and help our patients with tough
Yeah.
problems.
And so again, you're known for developing these personalized hybrid approaches, for complex cases. I'm wondering, how would you evaluate a patient's condition to formulate these customized treatment plans? If you're planning ahead, patients always ask, well, how do they know what to do? How do they know what they're going to do? What's the planning like for
Mm,
these
mm,
types of complex
yeah.
procedures?
Yeah, so knowing the patient is very important. Knowing the history of what they've been through and having trying to get as much information as possible is very, very important. And then imaging is huge in those cases. Like prior imaging, I try to have an amazing nurse who really knows how to get hold of all these previous imaging, because a lot of times you might understand something or know what happened in that case to kind of help you understand why did they do this? Why didn't they do something different? Maybe they ran into some problems and did something. So I think having all that information is very important. And a lot of times, these patients, we have, plan A, B, and C, and like I mentioned now with the advances in techniques and there's this pedal access, in the past, I mean, if you think about it, we used to just prep the groins and because that's what we used to access, or maybe the arm, if you want to come from the arm or the leg. Well, now we have other options. Now we can prep the entire leg because who knows, we might be able to stick the vessel directly in the thigh, or we have to stick a vessel in the calf or foot. So now when we do these cases, we have the whole leg prepped and in the field so that because we don't know where we might have to access to fix that blockage.
And I have just a couple questions before we get into our final six that we ask every doctor. You're just so knowledgeable that I think that you could answer some common questions that we get. For example, when a procedure is potentially needed, when it's not, because we have patients that'll come to us. I don't understand why my doctor is not treating me. I have a blockage. In what areas do the blockages really matter to treat, despite not having rest pain or wounds that won't heal on the feet, versus the ones that you're like, you know what, um, the ones you need to treat now? When and where are these located, and what do doctors use to make the decision as to whether or not they're going to manually intervene?
Yeah. So good question. So I'm going to answer evidence-based. I'm going to give you my opinion, if that's okay. So so again, I've been taught, and I teach my trainees, treat patients, not numbers, not imaging. So, and you'll be surprised. Sometimes we look at imaging and be like, oh my God, I can't believe all this blockage. And you talk to a patient, and the patient's like, you know what? I get by. I do my grocery shopping. Again, so I asked the patient, what do you like to do? Do you like to play tennis or golf, or just enjoy, some work in your yard and grocery shopping? Because that's important. I mean, if they're able to cut by and that's all what they want to do, and and I've had patients tell me, you know what, I walk, I get pain, I stop. I have to stop maybe once during my grocery shopping, but I'm okay with it. I want to avoid surgery, which is fine. I mean, that's reasonable as long as they understand where the problem is and how they can avoid it. But again, education is very important. Like I said earlier, I mean, I always educate them, especially diabetics. You have to inspect your feet every night. If you can't reach, look at your feet, have someone do it, or get a mirror to look at the bottom of your feet to make sure you don't have any wounds or ulcers, because that's important. That's actually will lead them to limb loss. So that's one. Two is we spoke earlier about the walk-in program. I mean, walk-in program is very crucial, and we have good evidence that it works in the right patient. So typically, in my mind, this works better for a patient what we call femoral popliteal disease, so disease or blockage in the thigh and the knee. And I've had a lot of patients, and I can share a story with you about a patient that I've had patients actually literally on the schedule for surgery or procedure, and they called, like, let's say a month into it, they're like, I'm actually doing slightly better. I want to wait. Sure. I mean, that's fine. Honestly, I think patients who have iliac occlusion or aortic iliac occlusion, those are the ones I personally have low threshold in treating, because we can make a big difference in their life and the quality of life, because the results are durable, with those like hybrid or stenting and in these patients. Because I have a lot of patients that come see me for second, third opinion, and because they cut down on cigarette smoking, but they're not completely off, and they're like, oh no, we're gonna do nothing. And some of them are pre-symptomatic, and I think those patients, in my mind, you can really help them by fixing what we call the inflow, like the aortoiliac segment or the iliofemoral segment, and they do well. Ideally, I want them to be off the cigarettes. I mean, I tell them that's how you achieve better long-term results. But in my opinion, these are the patients that we can definitely help significantly compared to the patients that have the femoral popliteal segment disease.
Yeah. And what about the below the knee disease? The ones where we find a lot of patients with diabetes, with I call it type 2 PAD. Type 1 PAD is more aortoiliac fempop disease that is like textbook intermittent claudication is really where it starts, right? But with this diabetic population and the chronic kidney disease population, we're seeing so much more where literally they don't get that traditional intermittent claudication that says ding, 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 ding. A lot of them develop numbness. They just don't feel anything. But it doesn't mean they don't have disease. How do you know in those patients? I had a patient call and he says, "Oh my God, I watched your video and it says that if you don't have these, symptoms, you shouldn't treat. If you don't have a wound, you shouldn't treat." And I was like, "No, you really misunderstood." He's like, "Well, my doctor treated." And I said, "Well, do you feel better?" He's like, I don't know. I'm scared." And I said, "Well, there are different aspects of disease that you have to really
Yeah.
take into
Yeah.
consideration, and there's a lot that doctors do consider, and especially with that complicated below knee disease. I mean, how do you know when to treat when they're not?
Yeah.
Maybe they don't have the wounds that aren't healing yet. They don't have the rest pain because they just don't feel anything.
Yeah. I can tell you, this is a great question. This is a tough one. So like you said, I mean, if they have a wound or rest pain, that's easy, right? I mean, typically those have what we call, like you spoke earlier, multi-level disease. But we do see patients, the diabetics, because they start unfortunately with what we call microvascular disease before it becomes a macrovascular disease, which is a bigger vessel disease, like you mentioned, the tibials. So I'll add to that. I mean, those are tough patients, and my advice for people treat them is listen to the patient. I mean, I really ask several specific questions because a lot of these patients have neurogenic or nerve-related pain from either the diabetes or maybe back problems, in addition to the PAD. So I think discussing with them like the type of pain and when it comes, what makes it better, what makes it worse, then I could say, you know what, most likely I can help you by fixing this, popliteal tibial disease. Or, you know what, I think this is something else. Let's do some further studies, whether it's EMG or lumbar
Yeah.
x-rays or something like that to see if this is a neurogenic problem or a PAD, or sometimes it's a mix. And I tell them, look, I'm going to fix it, but I don't know how much of your symptoms going to improve after a successful intervention, but we'll see. I think having that discussion with the patients is crucial. At least expectations, are so important, because the last thing you want is a unhappy patient. You put me through this procedure and I feel the same.
Yeah, it's one of the things we've seen quite a few times. We've seen more amputations without anyone trying anything or trying anything below the knee than we have anything else, more than 85%. But we still do have that set of patients, and we get the question all the time where patients say, "Well, my doctor wants to do this procedure or that procedure," and we've actually said, "Well, you might want to ask yourself, do you want the revolving door of procedures to start, or are there still things that you can do right now to mitigate your risk factors and maybe improve your prognosis and delay, maybe even prevent having a procedure at all?" How do you talk to a patient about weighing that and determining if a procedure is right for them? I know that's a loaded question, and you went through some of that with the aortoiliac and things
Mhm.
like that, but can you just there are just, as I said, a lot of patients that are faced with just, um, well, my doctor wants to do a procedure. My favorite is, my doctor wants to place a stent. And
Yeah,
that's the way they come at us. Anyone else have a stent? My doctor wants to place a stent. And my first question is, what are your symptoms? Number one. And then number two is, well, where and why do they want to place the stent? Is it in the iliac aorta? Is it in
yeah.
your heart? Is it in your carotid? Like, where here, or are you talking you have a thigh blockage and they want to go in and they're already planning to put a stent in there, which is destined to fail. Um, Most of the
Yeah,
doctors I know now tell me that they're not stent forward, that they try to leave nothing behind if it inflict at all.
yeah. Well, because unfortunately we've seen, a lot of patients who went for routine procedure and maybe didn't have, maybe mild symptoms, and unfortunately they had problems either with the procedure or the stent. And as you
Yeah.
know, that's now we're dealing with a rabbit hole and a different, all sorts of different problems. So, but let me, so you bring up a good point about patient, that when should we do something? So now, because that's something that actually is brought up quite a bit in like our conferences and our meetings, is that sometimes you see a patient with like a tissue loss, or let's keep it simple. Let's say just a small ulcer on the tip of the big toe. Okay. So, and then I see this a lot of patients be like, oh, I did ultrasound and, the ultrasound perfusion was fine. I'm a big believer in ultrasound, but again, remember, ultrasound is not 100% accurate,
Yeah.
so, and especially in these patients that have calcified vessels, it could be misleading. So what I tell my trainees is that, okay, as long as you have close follow-up with the patient, or also educating the patient, okay, we're gonna try wound care, because wound care also works. It's crucial for these patients. But I tell them, and then if the wound is not getting better or it's getting worse, I usually go straight for angiogram, because the angiogram is going to tell me exactly what's going on, where the problem is, and whether I can do something at the time of the diagnostic, like an intervention. And then I stand, but also if I can avoid it, I'm one of those. And I mean that we can talk about that at a different time. But also, if they candidate for a bypass, they have a nice vein. Guess what? Bypass with vein is durable. They do well. So I think so. I personally have very low threshold in doing an angiogram in patient with tissue loss. I
Yep.
think that's very, very important.
There's a lot that we had a patient in Oklahoma that comes to mind, and we had a surgeon in Oklahoma that wanted to do an angiogram. Something didn't feel right to him. He didn't feel like the ultrasounds were telling him, her symptoms spoke different. And she got scared going straight to an angiogram. She went over to a couple of other surgeons in the area, like, no, 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 no. Oh my gosh, don't do anything. And for him, it was more like, okay, I'm really looking at this as a diagnostic. I'm not sure what I'm going to find, but something's fishy here. And she came at us strong saying, oh my gosh, this doctor, and he wanted to do an angiogram. These other surgeons just made fun of him and criticized him and said he shouldn't. What do you think happened 6 months later? She
Oh,
ended
please.
up with a below-knee amputation.
Oh my God. Yeah. Yeah.
And this doctor was like, shoot, I wish she would have come back to me. I literally would have, I would wish we would. And they didn't even do anything. She came back and she apologized. She's like, well, and I said, why didn't you come back before you had the amputation? She said, I was embarrassed. And I said, so you got your leg amputated because you were embarrassed.
Mm.
And they did nothing. And I was so
Yeah.
sad.
Yeah.
And so I appreciate doctors like you that if something doesn't seem right, you kind of get out your nose out of the textbook and you say, you know what, let's just go in for an angiogram.
Yeah.
And I
Yeah.
also have, and especially before bypass, I'm hearing from a number of vascular surgeons that their philosophy is they want to make sure they do an angiogram prior to any bypass because they want to make sure that the outflow is is sufficient. So you turn on the faucet, the plumbing below is
Mhm.
looking good. And he said that one of them in particular said that there's just you just never are really 100% sure unless you go in and just to double check. We've had quite a few bypasses that have failed that we've sent back and said, hey, have your doctor check the outflow, and lo and behold, there was no outflow. And once
Yeah.
someone went in with a wire and balloon and just it open a little bit, the bypass had a place for the blood to go.
Yeah. Yeah. Well, unfortunately, the mistake I see with preoperative diagnostic angiograms is that people put the catheter in the groin or higher and they take pictures. I mean, that's not going to tell you what's happening in the foot and the tibial. So, and then again, I tell my partners, my trainees, you have to go as slow as you can, or if there's blockage, put a catheter in the profunda, because the profunda eventually, which is the vessel on the thigh on the side, that eventually supplies the rest of the foot to really
Yeah.
know what's happening, which tibial is open, what's the outflow to the foot. Because you're right, planning it for especially the patient that has a vein, bypass works well. And then I've done a lot of bypasses where patients said, "Oh, patient's not a candidate for a bypass," and that's another issue which Kim, you hear all these terminology, desert foot or no option CLTI. What does that mean? I mean, honestly, a lot of these patients come to me with those. I mean, I know people like to use it, for maybe, I don't know, for social media posts, but I saw a lot of patients that I'm like, no, there's a nice target there. I'll do the bypass tomorrow if you want. So yeah, I personally, I have a problem with all this terminology where I think it's kind of like easy way to say, oh, no, 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 you're not a candidate for bypass. When I hate to say this, a lot of them could be in the right place with the right person, could be candidate
Yeah.
for a bypass.
From the mouth of MacGyver here.
Yes.
Love it. So looking ahead, what innovations or developments in PAD treatment really excite you most, and how might they further expand our ability to save limbs in complex cases?
Yeah.
I know that there are a couple that, I don't mind if we mention a few, it's all fair game, but there's minimally invasive bypasses, whether it's thigh to pop to knee, fem to fem pops, or you have ones from, the DVA or TAD Vs from calf to foot. What are your thoughts? Oh, bioabsorbable stents versus retractable stents. Runs the gamut.
Yeah, no, there's a lot. And then I'd add to that also medication, right? Whether it's,
That's true.
yeah, and especially antiplatelet. I mean, I know there's some friends of mine who are, running labs, we're testing for antiplatelet activity and medication, because that's also another issue that we see some patients have what we call hypercoagulable state, and what
Yep.
can we do to help them keep things going. So no, you're absolutely right. There's a lot happening, and that's why, in my opinion, and also being the chief, here, what I would like to see is, and also in vascular surgery, we can't do it all. I mean, you can't be MacGyver of aneurysms and PAD and venous disease. I really think that eventually we need people to specialize in those certain areas.
Hmm.
And let's say, I'm on call, patient comes in with a cold leg, yeah, I can fix it, do the bypass, whatever needs to be done. But if it's something more complex, and one of my partners does some advanced PAD work, I'd be like, hey, can you please take care of this patient? And I think that's what we should start doing, is that we need to have people, experts in that field, PAD, open endo, and really take this to the next level, and and then be part of the development of technology. Whether like you mentioned, tibial vessels, we still don't know what's the best treatment. Is it atherectomy?
Yeah.
Is it bioabsorbable stent, or something else? And the bypass, we always forget about bypass. And I can tell you how many times patients come in with like occluded stents, and then we try to open it again, and you try to open it, and then find it like, hey guys, how about a bypass? Like so I think there's a lot. It's very exciting. I mean, I think PED, from like innovation, from research standpoint, it's still, I think the market is, I mean, it's wide open, and eventually, I personally would like to have someone kind of take this on and run with it.
And that's something that we're trying to do with the Global PAD Association. I think I can't remember if you're invited to be on our medical board of advisors.
Oh, okay.
But one of the things we're looking to do is to create a database to allow doctors to say, this is what I specialize in, this is what I love to do, and this is what I can do. These are the patients I prefer to treat. And let's get them into our database so that we know who, what, when, where, why, and how when we're sending patients, because not every doctor is
Mm.
right for every single patient. Even personality matters, insurance
Yeah,
matters, geographic
yeah,
location matters,
yeah.
right? So it's really important, and that's something that we're working together, we're putting together. So would love to
Mhm.
have you on that, because you have
Yeah.
some really great ideas, and especially being MacGyver, maybe you could help us add a few more fields on there,
Yeah,
um, into our form.
yeah.
But I have a speed round here.
Yes.
So we'll get through these. I ask these of every single doctor. The first one is, describe a case you learned a lesson from that other physicians or clinicians, this is geared towards physicians and clinicians, what they can learn from. It could have been a success, it could have been a failure. We've had both.
Oh boy, that's a interesting question. I mean, I learn a lot. I mean, I tell everyone, the day I stop learning, I'll probably just quit my job, because every day is a learning day, and every patient with PAD is a different. But honestly, since I'm treating a patient recently that I probably should have paid more attention to the patient. And one thing which also is unrecognized is internal iliac artery disease. And so this patient had claudication. I mean, I kind of listened to the patient, but I missed that the patient was having more buttock claudication, and I really thought it was coming from his aortic iliac disease, and actually it turned out to be more related to his internal iliac disease. And even though, like, yes, we help the leg, but honestly, I think there's something which is undertreated, or the internal iliac disease, which supplies the pelvis, which could be related
Mhm.
maybe to impotence, even though that's a different. I mean, there's a multi-factor problem.
Factorial. Yeah.
But I think internal iliac disease is an area that is under-recognized.
That's interesting. We have quite a few patients with that. We've had doctors that have refused to treat that, saying it can't be
I
done.
have I have one coming up. I'll let you know. I'll let you know how we. I think I'm going to help him, because he's a classic buttock claudication with bilateral high-grade internal iliac artery disease.
I would love to hear the result. That'll be really good. I mean, I know some areas with some, patients, it may not have access to what you're able to do, but it's nice to know and gives them hope that maybe that's
Yeah,
something that could roll out over
yeah,
time if it's something that works for you
yeah,
and you end up teaching other doctors as you do across the globe.
yeah. I'll let you know.
Describe a case where patient should have been diagnosed with PAD sooner but wasn't, and this is a lot of cases, and they presented on deck for complex revascularization or amputation. And it's really to raise awareness for our Journey to Diagnosis series, where we're trying to get to people who have the misdiagnosis that's really stereotypical, where they say, oh, it's just your back. Oh, it's just your diabetes. It's just neuropathy. It's just arthritis. And so we want to kind of really be able to, hammer that in for patients to say, hey, if you are getting diagnosed with these things and nothing seems to be helping, get that circulation
Mm,
checked.
mm. Well, I mean, you already said it. I can't tell you how many. Even I think 6 months ago, I had a nurse come from see me. I think she came from Indiana, and everyone kept saying, "Oh, your legs, it's your back, it's your back." She got injections. She got. I mean, she had previous back surgery, and no one bothered to feel her for a femoral pulse, which she had none. Again, physical exam is a lost art. I have some white hair, so I'm maybe a little bit on the older side, but I hate to say this, physical exam. I mean, we rely so much on diagnostic testing, and this lady, sure enough, didn't have a femoral pulse, and then obviously that triggered PAD workup, and she had really bad problem. And obviously she was miserable for years until we fixed her, and obviously now she's happy and she's able to walk and do it and enjoy the things she likes to enjoy.
Yeah, I would say 2 fingers, 2 seconds to feel those like pulses, and life and
Yeah.
limb can be saved. It's funny
Yeah.
with my mom. She had an abdominal aortic aneurysm, and we were at the doctor literally the week before, and she was still complaining about these symptoms. And he called me afterwards, just apologetic because she
Mm,
passed. And he said, Kim, if I had only touched her,
mm, mm.
he's like, I know I'm opening myself up here, but he's like, I hope you take it in the way. I wish I would have touched the patient. I wish I would have touched your mom, and I
Yeah.
didn't.
Yeah.
And so that is a lesson, that it's just hard lesson, but
Mm,
it
mm,
was important that,
mm.
he can help other patients now. Okay. So share a story of a patient who impressed you with their effort to improve their PAD prognosis through their own perseverance. They may have been on deck for amputation and they said,
Yeah.
no, doc, I can do this. I'm going to go walk. I'm going to change my diet.
Yeah. I have a lot of those actually.
Yeah.
But there was one patient, I actually give credit to his wife more than him. So he, which also not unusual. We hear patients had bilateral saphenous ablation. They had pain with walking or heaviness. They had their saphenous vein ablated, and they're like, my symptoms haven't changed. And then sure enough, oh, you don't have pedal pulses. Let's do ultrasound. And that particular patient, had bilateral SFA occlusion. So both were out. And they actually consulted with a surgeon, and they wanted to do a bypass using arm vein. And finally, the wife was like, you know what? Let's get second opinion or something. And then she found me, and they came to the office. And I was like, we can do the surgery, but there's something called walk-in program. And the patient was like, I'll do it. I'll do it. I don't want any incisions. I don't want any. If you tell me that helps, and I think it does help, especially in non-smokers. I do believe walk-in program in the right claudicants, it does help because with smoking, it doesn't let those geniculars or collateral pathways to develop robustly as and patient non-smokers. And yeah, this patient is like walking, doing everything he can to follow, appointments, follow up. He still comes see me for a routine evaluation to make sure the PAD is not getting worse, obviously. But yeah, he tried everything to avoid the knife and surgery, but I told him he has to give credit to his wife.
Our next question is share your best motivational speech for walking as medicine. It's actually pretty motivational. But if you had another one where you explain how the body builds the collateral vessels, how it builds the natural detours, we're open to that as well as part of our next
So
question.
patients then so I have in the office in the clinic we have and then when I actually came to Rush, they didn't have them, and I asked for the manager to buy pictures of the vascular system. Because when you stand with a patient and you show them where the blockage is and you try to point where collaterals are, which geniculars are, which are part of the collateral pathway, they understand what you're talking about and how those get better and bigger over time, and they can avoid surgery. So I think having that in the office where you can point and tell them what's going on and what they can do to help, and patients get it, because like when they come for the follow-up, they're like, hey, did my API improve? Or like they're like excited when they see, even though like I tell them, look, I mean, not necessarily it has to improve. Stable is a win. We don't want it to get worse. So, but it's funny to also hear the patients that they're engaged in their care and they want to know if what they're doing is helping.
Our patients came up with the idea they wanted to have, like, there's this organization does Rock Your Scar, and they were like, we need a rock your collaterals. And I said, I don't know if that's possible if we can get images of collaterals for everyone, because
Yeah.
there's a lot that goes into getting that sort of imaging. But they thought, well, is there a way that doctors on their wall should do like a collateral wall of fame for those patients that really maybe
Yeah.
were on deck for amputation and walked their way, to celebrate, their ability to keep their legs.
Yeah.
So
Yeah.
just kind of funny. Two more questions, one deep, one quick and
Yeah.
fun. We want to hear a defining moment in your career, what we call our 6 minutes that matter. It could have been a conversation, a scene in a movie, a documentary, something you watched, a moment with a mentor. It could have been even at the airport, someone you met there that you had a 10-minute conversation with, but something that created an inflection point in your career philosophy.
Well, are you able to see that picture behind me? I don't know.
Yeah.
It's probably not very clear, but that's actually Dr. DeBakey. Dr. DeBakey is considered, the father of cardiovascular, or he's, if you are in Houston, you should go to visit his museum, at Baylor College of Medicine. It's really amazing what he's done. So before I graduated, I took a picture with him. He was close to 99 years old. Yeah, and he actually had just recovered from a major surgery. But I asked Dr. DeBakey, give me one advice. I'm gonna be leaving with this fellowship. I'm very well trained. I'm capable of doing, helping my patients, the community. But what advice do you have for me? He just said one word: repetition. And then he looks at me. He's like, do the operation, keep doing it, and do it better every time. Um, maybe people might think it's not much, but I mean, this is coming from a giant in our field, and basically what he's telling me is that experience and improving every time you do the operation, whether it's the same operation or something different, do it better, do it more efficiently, and
Yeah.
and learn from it. I mean, those. So that honestly, that's was really a powerful, story or impact on me.
Repetition, and that's how you become the
One
MacGyver you
word:
shared earlier.
repetition. Yeah.
Right? You said that it was
Yeah.
over time that you're like, you just kept doing it, kept doing it, kept doing it, kept learning and growing.
Yeah.
And so that's
Yeah.
amazing.
Yeah.
Okay, final question. A little bit of a fun one. A moment. This one is from the page. The patients really want to know this. They created our final question.
Okay.
A moment with a patient that still has you shaking your head, something that patients can learn from, mistakes patients make and can, help make sure they don't do it. It can even be, I can't believe a patient just said that or did that. And I could give you an example of, and it's not to make fun of patients. It's recognizing that, sometimes we just don't know what we don't know, and we're just trying our best and doing what we can. And one of our, Dr. George Adams from UNC Rex shared a case yesterday where the patient needed to lose weight desperately and said, hey, doc, I'm going to do this before we do any other procedure, anything else. I'm going to lose the weight. I'm going to do this with a cleanse. He's like, I don't know anything about cleanses. He's like, oh, don't worry. I have some friends. We're all going to do this together. And suddenly he appears in the emergency room, and Dr. Adams gets the call and he says, I'm having trouble with my heart. So he was in AFib, and Dr. Adams says, like, what triggered this? There had to have been something. The patient goes home, a couple days later, calls him and says, oh, I think I figured it out. That cleanse that I was doing, well, I actually applied it wrong.
Oh
Dr.
boy.
Adams is like, what do you mean? He said, well, it was an enema and I used it in the wrong hole.
Oh, oh
He
wow.
did it
That's
orally, and I
yeah,
guess as many as he did sent shock through his system and whatever was in there.
yeah.
And so that was his story. And I was like, okay, definitely one to learn from. And we had one more where, bless their heart, a patient was trying to keep up her socks, diabetic patient, put the rubber band around her leg and was like, okay, that's not working. So she stapled the socks on. And she thought it worked really
Yeah.
well until she took the staples out. Still didn't feel a thing because she had numbness and it all got infected.
Mm.
And Dr. David Alper said, you don't staple your socks on. So I give you a few ideas.
Yeah. Oh man. I mean, I don't know if I can top these stories. Well,
Probably call me later and you go, oh God, I thought of one.
oh, I'm sure. I'm sure. Yeah. I wish I had those questions ahead of time. I would have thought of.
I should have
Um,
sent them. I'm so sorry.
no, 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 no. It's fun to have it on the fly. Well, I this was a while back. I had my nurse practitioner call me, and I could tell like she's embarrassed, and she's like, "Dr. Bechara, I'm sorry, I have to ask you that question, but remember this patient X you did the bypass last week? I mean, not even. It's been only a few days. Like patient went home, and I'm like, yeah. I mean, is the patient okay, or like what's going on? They're like, um, she's having some problems with the groin incision and she's having pain. I'm like, everything was perfect. She's like, okay, well, I'm gonna tell you. She had sex last night with her partner, and and she was telling her like it was really, you know, um,
Pretty active,
yeah.
pretty
And I'm like,
exciting.
oh my God. I'm like, and then my nurse practitioner was so embarrassed to tell me the story. Luckily the patient was fine. I was like, well, I have to check the groin just to make sure, that there's no bleeding or something. And then obviously the patient
Yeah.
comes to clinic the next day and she's embarrassed because she had to tell her the story. And it was funny because she came with her partner and they were like, we kind of made a joke out of it. She's blaming him, he's blaming her. And so we kind of made it like it's a joke. So and we took care of the patient. But yeah, that's the only thing that kind of comes to my mind right now.
But
Yeah,
I mean, that is so real because we get questions, a lot about it's a real issue when it comes to sex. A lot of patients have a lot of struggles, right? When they have lack of blood flow. And I'm sure you made her feel so good with more blood flow that she's like, game
yeah,
on,
yeah.
let's
Again,
do this.
exactly. Yeah, but
But
I was
it's
like,
probably
next
now
time.
changed your
Yeah.
your protocol and the discharge papers.
Yes.
And when you're like, and by the way,
Yeah,
not making assumptions here,
yeah,
but you might want to hold off for a few days.
correct, correct. That's funny, but anyway, it's all good.
So thank you so much, Dr. Bechara. We really appreciate you. Everything that
Thank
you
you.
do to save life and limb. On behalf of the Global PAD Association, through the Global PAD Impact Awards, our PAD MacGyver of the Year Award for 2025 goes to Dr. Carlos Bechara of Rush Hospital in Chicago, Illinois. Well
Thank
deserved.
you.
And thank you so much, Doctor, for all you do to save life and limb.
Thank you. And you guys also keep up the good work. I mean, helping patients reach out when they're helpless and in need is huge, you know.
Thank you.
Thank you.